mostly sunny, and the temperature is about 15, 16 degrees Celsius.
Oh, great. Good.
Yeah.
It's very cold.
And there you are in Dubai.
We are in Abu Dhabi.
In Abu Dhabi, so Abu
Yeah,
Dhabi.
let me check for you the temperature. We don't have winter this year. No winter.
24 degrees, doctor.
No winter. No, neither did we.
23. For us, 23.
23, yes, but now is 15. So
Which is good.
January is supposed to be much colder than this.
Yeah, maybe it's worldwide.
But no, it's southern Italy. Northern Italy is completely different, the situation.
Yeah.
Doctor, can you try to share your presentation so that we can test?
Yeah. Let's check.
You have video on your presentation?
It is on my desktop. I put the. Do you want that I share?
Yes,
Yeah.
doctor.
Let's check. No. Is no. Is not possible. I cannot share my screen.
Just a second, doctor. Let me check. Okay, can you try now?
Yes. Now I can.
Okay.
Let me check. Yes. Yes. Where is my desktop? Where is my desktop? Excuse me. The screen. Excuse me. Let me check. There are so. There are too many windows open. Now I excuse me, but as a bit also we try to where is it? I can't find my desktop.
Maybe you should minimize this one, the Zoom.
Yes, I have already put, but I can't see on my the share to let me see. Let me
Now
see.
I think you are sharing.
Yeah, I think you're sharing.
Are you sharing?
But the presentation is not showing.
No, but it's not this one. Yeah. No, it's not this one. I need to see my. Let me see. This is a screen.
Yes, just doctor. Just open the presentation, minimize this one.
But can you see me? Yes. Now I'm trying to share. I'm trying to share my presentation.
Okay.
Can you see me?
How can I pronounce your name?
My name?
Yeah. How can I pronounce it?
Guido. It's not very difficult.
Again, it was disconnected for a while. Guido?
Fadda.
Guido
F-A-D-D-A.
Yeah, Guido Fadda. Okay.
Yes, absolutely. Perfect. It's a bit slow. I don't know why, but it's a bit slow, the sharing of this. But I'm seeing there is loading the presentation.
Yeah.
It's not really heavy, so that's the probably is there are yes, there are some pictures, but really don't. Oh, yes. Can you see?
Yes, doctor.
Yes,
Just
yes.
But they are empty.
make it
No,
full
no,
screen.
no, no. Don't worry. Yes. Yes. So I go to in the presentation mode.
Yeah.
Yeah, let's check. It's very slow. I don't know why, but that's the yeah.
Excellent.
Can you see now we try to move it. I don't have
Yes.
any movies on
Yes.
any videos, so is yes.
Should be easy. Good.
Yeah. So
Excellent. Thank you.
yeah. So
Okay,
so
doctor.
we can stop the presentation.
Okay, doctor.
The
Also, doctor, if you can move a little bit, move out because maybe the audience will see only your head. It's very. Can just adjust, please, the camera stuff.
This one
Yes, doctor.
is better.
Move a
But
little.
well, during the presentation, probably they will look at the presentation, not
Yes, doctor.
my
It
face.
will
But
be the presentation, doctor, and your face. I try to swap either both of it, or either
uh,
you can switch also to only the presentation.
What do you prefer?
no,
No, I said just we keep him because you know
Yes,
why, Dr. Fadda? Because all
Mhm.
these presentations are recorded and will be uploaded in the hospital website. So we
Mhm.
can remember your face.
If do what do you think is best?
yes,
Okay.
doctor.
Because
I will just handle it. No problem.
yeah,
Right.
let, let
And
me
doctor,
know.
you will introduce Doctor Guido.
Hmm?
Sorry?
You will introduce Doctor Guido,
Yes,
right?
I will, of course.
Okay. Okay.
You are the Dr. Rania. You are the moderator of the session.
Yes. Yes, I'm Dr.
Perfect.
Rawia.
Perfect.
Yes, I'm the moderator. I am the chair of this event. It's a monthly event. We started May 2023. We have some really keynote, brilliant speakers from Hong Kong, you, from Italy, I have one from China, and from US, quite multiple from Mayo Clinic. So
Yeah.
and it's a free registration, so many people join. We have people from Japan and Mexico, Middle East, Morocco. So
Yeah.
hopefully we have a great discussion and talk, I'm sure.
But which is the average of graduation degree of the
Okay.
participant? Are they
Okay.
cytopathologists, cytotechnologists,
Okay.
physicians?
Okay, most of them we have a pathologist, and we do have cytoscreeners, but the number is so little for the cytoscreener, and students, healthcare workers. So I would assume we'll have inshallah a good number this time.
Others, no, just sometimes I have, excuse me, the allotted time is 1 hour probably.
Yes.
Yeah, including the discussion and everything.
Because I have rehearsed my presentation is about 15 minutes. It's
50?
too long.
50?
Yes,
That's fine.
that is
And
about
later,
this because
yes.
I will maybe I will focus on some in some areas I will probably I will discuss some trivial or very basic parts of regarding the cytology, thyroid
Oh, yeah.
cytology on liquid or thin prep cytology, but thing probably is that if there are some students or some healthcare workers, probably can be useful.
It is. It
Otherwise,
will be useful, I'm sure. Even for us, we like to go back to the basic and, know all of this. Yeah, no, please do it.
yeah, trying
And
not to go too much beyond the allotted time, of course.
Yes,
But you have already received the PDF of file of my presentation, so probably people will have an idea of the presentation of some parts of the presentation. So it's easier for me.
Thank you.
Yeah.
also, Dr. Guido, by the end of your presentation,
Hmm?
maybe Dr. Rauya can read the question and answer if there are question and answers that is given by our attendees of this session.
Excuse me?
He
By the
said,
end,
I will read some questions at the
Yeah.
end, just for this.
Yes, not ask, read.
Yeah,
yes,
I'll
They,
read some of those
yeah,
questions
yeah,
written by
yes,
the
yes.
audience. Yeah.
Absolutely. I'm looking forward to receive some questions. I hope so.
Hope so. Friday is
Uh,
quite difficult for us here. It's a half day work, working time. They look forward for the weekend. So let's hope they are engaged.
Yeah, no. Your day is your work day is at the end. We are at the begin. No, not at the
Yeah.
beginning, but in the middle of the day. So we have.
Yeah.
I have also another Zoom meeting in the afternoon for the organization of the International Congress of Cytology in Florence in 2025.
Oh.
So we have a lot
Wow.
of things to do, but
Yeah.
I'm very happy to be with you.
Thank you very much.
Yeah.
Thank you. It's our pleasure.
It's a I think can be a interesting experience. I will try to share with you our experience, particularly in the since we have sent and Professor Rossi from Catholic University in Rome has sent and has been accepted at the United States and America and Canadian Academy of Pathology in Baltimore in March. We have a presentation, an abstract on our experience with a 20-year experience with the thin prep in the thyroid, only thin prep, 20 years. So I will share with you from the beginning, beginning, the reasons why we have decided to move to thyroid fine aspiration. There has been also some problems, but I want this.
I am one of the people, maybe, my experience is much less than yours for sure. But I am one of the people when I receive a thin preparation for thyroid FNA, I get so irritated and I hate to report it unless
Yes.
it's very clear and there is like all the features there. Otherwise, I will ask them to repeat. I'm used to the smear. I'm used to this. So
Yes, I know. But what you can imagine, I must confess that at the beginning I decided to uh, to adopt the system of ThinPrep because there were so many. We are in at Catholic now I'm at the University of Messina in Sicily, and now Messina we have shifted also to the from conventional to ThinPrep, but at the Catholic University was a reference center for the thyroid cytology in Italy. So we had about 3,000 fine needle aspiration of thyroid per year. And you imagine, probably it's your experience. You have so many slides to look at, to diagnose, to sign out. And if the operator is perfect, you can do everything you need. You can, the diagnosis is simple. You have a good relationship with the clinicians, with patients. But if the operator is not very skilled and it put a lot of fibrin, of clots, blood clots in the, and you have to read them, to look at the slides, and you cannot make a diagnosis. It's a really frustrating experience.
yeah.
So we have decided to remove plenty, I would say thousands of useless slides with the blood, and put everything in one slide, at least one slide instead of 20, 30, so on. That was but
we need training.
But you can imagine that was really difficult because the pillars of the diagnosis are, they fall completely. So you are in a wide sea, open sea, and the majority of people were not absolutely interested in ThinPrep. So they couldn't give you really a help for. So we started with a bot. We did and we realized, I will show you in the paper we published in 2009, the first experience, that with the bot, the bot sampling, the one dividing, one for conventional and one for liquid-based cytology, was really a mess. Because usually people do not know how to divide the material. So usually there were a lot of blood clots in the conventional slide and nothing in the liquid-based preparation. So the diagnoses were absolutely, exceedingly difficult. Then we decided on November 2003 to skip. Is the end. It's over. We go ThinPrep. They go liquid-based.
Okay.
And just to say, do you know what has been the most difficult? Or when we realized that the technique was suitable, when after maybe 1 month or so, we achieved, or we signed out for the first time at papillary carcinoma. Because before, when you sign out goiter, well, that's where. When you sign out indeterminate. Well, but when you sign out the papillary carcinoma, you must be very confident that the technique is perfect.
Yeah. Well, here we have one laboratory, I know. It's a reference lab. They are using ThinPrep for all the thyroid. When I heard that, I was so like, oh, how they do that? But it's a private lab.
Yeah.
Yeah, and they have a lot of load. Let me see. The cytoscreener should attend. She is going there. She is appointed there. So she's interested to know more about this. So I'll tell her that.
Yeah, I know.
Yeah.
I will address also the diagnostic, the morphology.
Yeah. Michelle, don't
Doctor,
forget
we
to
will start
attend
at
a
3 minutes, okay?
He is discussing the ThinPrep and thyroid. We are just having some discussion, just like what we did today in the morning. So yeah, let's see. All right. Okay. Thank you. Bye. Bye. I'm ready.
Of course, I will address also lung cytology, because since 2010 at the Catholic University, also here in Messina, we are the majority of all non-gynecologic cytology is processed by liquid-based cytology. So we have experience with the urine, with the lung cytology, exfoliative and aspiration, salivary gland cytology. Of course, I will address a few minutes for salivary gland cytology. Well,
that's difficult.
Yes. Well, of course, thyroid will be the most important, because I will give you our experience, particularly with the use of additional material, but also for other fine needle aspiration. We have a good experience with the liquid-based cytology, and I think it's important because now molecular studies and molecular techniques need to be applied to everything for the diagnosis of cytology, for the diagnosis of non-gynecological, even cervical cytology, but not only, also non-gynecological cytology.
Excuse me, doctor. We will start within 1 minute. Just be
Sure.
ready.
Within yet?
Yeah, okay.
So I will introduce you first, and then we can.
Yes, doctor. I'll just make you spotlight.
Then I will share my presentation.
Yes,
after
doctor.
Yeah.
Yes, Omar, we are starting in 1 minute. Sorry. Okay.
Okay, I will count from 5 to 1. We will start. Just a second. Okay. Okay, 5, 4, 3, 2, 1.
Hello, good afternoon, everyone. Welcome you all in our 11th session of the Abu Dhabi Surgical Pathology Journal Club, and it's the first one for the year 2024. Today we have Dr. Guido Feda with us. I'm very happy to have him with us today to speak about some of the ultimate challenge in ThinPrep of different cytology specimen. Dr. Guido is a professor of pathology at the Department of Human Pathology of Adulthood and Developing Age at University of Messina in Italy. He is the head of the interdisciplinary program in pathology and the vice chair of the Department of Diagnostics at the University Hospital in Italy. He has more than 214 research publications, has written over 14 book chapters, including 2017 and the 2022 WHO classification of tumors of endocrine organs. So without any further ado, let's welcome Dr. Guido Feda. It's all yours, Dr. Feda. You are mute. We can't hear you.
Yes. Can you hear me? Good
Yes.
morning for Italian and good afternoon for Middle East. And thank you for Dr. Raya Mubarak for the kind introduction. And I will try, first of all, to share my presentation. Can you hear, can you see my presentation?
Yes, we can.
Excuse me, but I don't know why it's yeah, good. Well, thank you. And thank you for inviting me. The presentation today, the topics will be the liquid-based preparation in non-gynecologic cytology. Usually I start my presentation with this slide and this statement, which I strongly believe in, because cytology is I think is the most intriguing diagnostic challenge of the 21st century. As Dr. Papanicolaou has demonstrated, screening and prevention were invented with the cytology. The diagnosis, of course, we will address the diagnosis, but we also will address in part the prognostic parameters for some tumors. And also we addressed the very recent subject of the prediction of therapeutic response. Of course, the follow-up of is important, the cytology for the follow-up of some tumors, particularly the tumors of the urinary bladder. Well, first of all, let me start with the advantages of liquid-based cytology. Liquid-based cytology, well, the problem of liquid-based cytology is first of all, the needleless syringe are rinsed in a hemolytic and preservative solution. So it's very important to, particularly in some organs like thyroid, which have a rich vascular network. So it's important to eliminate the blood clots that may obscure the region, the appreciation of the details of the nuclei. But it's also important because we skip the smearing step. The smearing step is in a fine needle aspiration is one possible source of bias, of the source of inadequacy, because the cells, sometimes inadequacy can be related to the small amount or insufficient amount of cells, but sometimes is related to the sufficient amount of cells, but the cells are for crushing artifacts, for air drying and poor preservation, the cells are not suitable for a diagnosis. But also important is that all the material is processed and the procedure is standardized. Not all the material is present in the slide, which is obtained, taken at the end of the procedure, but is also a mix of all the cells of the material which is present in final vial. The cells are immediately preserved, and the red blood cells and the fibrin alizate, we have already said that. The cells are collected on a thin layer, and we'll see that this is can be important detail. At the beginning, when we decided to introduce the team prep in our practice in our lab, the final sentence that a portion of the material can be stored and used for additional investigation was not really the most important part, or the most important reason why we decided to change our system. But now we can say that is really a very important issue to take in consideration. So the practice is easy. You have only to rinse the syringe, the needle in an hemolytic solution. The needle may be left in the solution. This is team prep 5000 for many or for several samples. But the most important is the comparison between liquid-based cytology, one slide at the bottom of the tray, and the conventional slides, 10 slides at the upper part of the tray. The most important is that you can, with one slide, you can save the vision, the observation of 10 slides. And sometimes if the workload is very high and you have many cases to look at, sometimes can be useful to preserve the site, to preserve your concentration during the day. And this is a very recent papers of 2022 when 2020, where Dr. Heinemann and the group demonstrated that the stability of DNA and RNA were function of the days from the sampling, so the storage days. But if probably can be important for DNA, as you can see in the upper scheme, you can see that for RNA there's no difference in the days. I will show you some results related to the isolation and purification of DNA or RNA, even 6 months after the storage, after the sampling with the cells which were stored in the preserved cyto solution after 6 months from the sampling. Of course, there are also the limits. It's not cost effective in the short term, even if you know that cytology is not really a high level budget usually. Increase the technical workload, but sometimes the technicians are really happy because the material for the standardization, and you know that after a learning period, the machine, the technique is not difficult. We will address in detail the morphological features which are different in conventional smears compared to LBC slides. I will anticipate that people who are expert in conventional cytology, they usually do not find any particular significant difficult in looking at the cells in LBC slides. 2 years ago, the slides is of 2 years ago. Nothing has changed except the last sentence. The on-site adequacy of the experimental material cannot be performed. And in 2022, we have been changed. I have to make up my mind, because this paper and that the United States demonstrated that the liquid-based rapid on-site evaluation of endobronchial ultrasound cytology is very important because of the storage of material, the possibility to divide the material for diagnosis and molecular studies was possible. So we have to cancel the last problem for liquid-based cytology. The fields of application of liquid-based cytology, virtually all fields are suitable or are good for the application of liquid-based cytology. Fine needle aspiration cytology, pulmonary lesions, hepatic and pancreatic lesions, salivary gland lesions, breast lesions, nodal lesions, thyroid lesions, but also exfoliative cytology, serous diffusion, urinary cytology, cerebral spinal fluid cytology, bile duct cytology. I will start with the thyroid lesions, not only because it's a really very interesting field, and it is a very interesting also from the scientific viewpoint, but also because I had and our group of the Catholic University of Messina, we have a really important experience in thyroid lesions, and I will share the history of fine needle aspiration cytology at the Catholic University of Rome. We started in 1999, and since November 2003, all thyroid aspirates, and since 2010, all non-gynecology cytology at Catholic University and also the University of Messina are processed by ThinPrep only. So the first option is ThinPrep. Then, in selected cases, if needed, we can use conventional transmission or, of course, other systems, techniques for processing cytology. I will give you I will explain which has been our experience, and I will comment on a paper we published in 2009, the first most important in 2009, regarding our experience. This experience collected the data from 3 reference biennia. The first one in 97, 98, where all fine needle aspiration, thyroid fine needle aspiration were processed and the conventional direct smear conventional techniques. The second was a learning period when the thyroid cytology was processed with both conventional and liquid-based cytology. And then we will make a comparison with the last period when the only liquid-based cytology was adopted. We studied more than 10,000 thyroid fine needle aspiration, but the most important, we chose 3 parameters of efficacy. First of all, inadequacy, which expresses the overall efficacy of the technique. Of course, if you have more than 20% rate of inadequacy, probably you have to change something in your technique and on your lab, on your system. Indeterminacy rate is a parameter of low confidence of the cytopathologies. If you cannot make a diagnosis, or if you don't feel confident in making a diagnosis, probably you will give a diagnosis of indeterminate. So it's like a certification of inability to make really a good, correct, definitive diagnosis. On the other hand, the malignancy rate expresses the confidence of the cytopathologists. If you are not confident in your technique, you're not confident in your system, probably you won't make a diagnosis of carcinoma in the thyroid, probably in any other field. We see from this scheme, this chart, that the inadequacy was very low at the beginning when everything, papers, the fine needle aspiration were processed by conventional. Particularly, in that period, we did also the rapid on-site evaluation of the material. Then the inadequacy rose to almost 20%, probably because of the difficulty in the operators to divide the material between the glass slide and the liquid-based cytology, with the difficulty in evaluating the characteristics, the morphology of the material in both the techniques, the both slides. Then when we shifted to liquid-based cytology, the inadequacy rate decreased less than 15%. And now we published in 2017 at Catholic University more than 4,000 papers. We are about 11% inadequacy rate. No, excuse me. About 8% of inadequacy rate. Regarding the indeterminates, we see a very analogous trend. At the beginning was in with conventional were about 15% rate, then rose to almost 25%. Then with liquid-based cytology, we had about 15% again. With the malignant diagnosis rate, we see that absolutely the same. So if the confidence were the same, and we can see that the rate of diagnosis of malignancy were about 3%, so not so many. So the morale of this paper, of this study, after 2 years of application of liquid-based cytology, was that at the beginning we did not harm the patient, we did not harm we did not impair the efficacy of the techniques for the patient, for the diagnosis of the patient, for the treatment of the patients. And now we see which are the most important difference between the liquid base and the conventional material processing systems. With the goiter, we know that in conventional, the diagnosis is based on the presence of colloid and the morphology of follicular cell thyrocytes. When we have conventional smears, we know that colloid is smeared in the background of the glass slide, so we don't need to count the amount of cell or try to find a quantity, because qualitatively we can absolutely abscess identify the colloid in background. Of course, the diagnosis is based on the morphology of the thyrocytes, but sometimes when the colloid is very abundant, the cellularity may be limited. In liquid-based cytology, we know that even with a large amount of colloid, there is the filtering step. So the material is filtered and the colloid is fragmented by going through the holes of the filter. So the amount of colloid should be considered quantitatively, because the higher the number of colloid droplets, the higher the likelihood of course, a lesion, benign lesion with a lot of colloid. But we cannot forget that the sheets of thyrocyte should present thyrocytes with regular nuclei. And this is a typical case of liquid-based cytology. Many droplets of colloid and amphiphilic, the center orange, the borders blue, and we can see that some small thyrocytes with the nuclei, dark nuclei, absolutely normal. We can see the comparison between liquid-based cytology with two colloid droplets and direct smear, when we see that colloids is in the background of the glass slides. Chronic lymphocytic thyroiditis, the difference are the opposite. In conventional, during conventional, which usually is a poor amount of colloid, the background cells usually are devoid of colloid in the upper plastic nodules. But we can see the lymphomonocytic inflammatory cells in background. And the amount of lymphocytic cells means the diagnosis or the possibility of chronic lymphocytic thyroiditis. In liquid-based cytology, instead, even there is a poor amount of colloid, but the lymphocytic cells, the isolated lymphocytic cells, usually they go through the holes and they are lost. But the lymphocytes, which are admixed in intimate contact with the thyrocytes, they form the so-called lymphoepithelial clusters. So also the presence of scattered, maybe not so many lymphoepithelial clusters, but presence and identifiable are really the clue for diagnosing a chronic thyroiditis on liquid-based cytology. And we can see that the liquid-based cytology, the lymphoepithelial clusters, whereas in a direct smear, we see we don't need a lymphoepithelial cluster. We see that lymphomonocytic cells are in the background in the spaces between the cells. And we can see the lymphoepithelial cluster with the larger nuclei of the follicular cell and the smaller dark nuclei of the lymphocytes. This is the scheme depicting the reporting system for UK, for Italian and Italy, and at the end of this year will be published the new update of the Italian reporting system and the Bethesda system, which updates have been published at the end of the last year. We can see the six categories, which are in the Italian and British system, have been subdivided, further subdivided, the 3A, 3F for British, 3A and 3B for Italian, whereas in the Bethesda system, six are present, are not so subdivided. And we can see that indeterminate, we have already So far, we have discussed the benign lesions, but we can see that indeterminate and malignant lesions are important also for the diagnosis. But in these cases, I will show some examples. This is an indeterminate, low-grade indeterminate, so-called house in the Bethesda system, and we can see that the nuclei, there are many cases. The colloid in the background is poor. The cells they do not present nuclear atypia, and there are some follicles, microfollicles, but really is a low grade indeterminate. In this case, we can see that the presence of macrofollicles is much more important, much more significant, and the cells have really slight mild atypia, and this is called indeterminate high risk by follicular neoplasm in the Bethesda system. And we see really the severe atypia. The severe atypia means that the nuclei are large, clear, and irregular. But we'll see, now I will show you the oncocytic cell. Oncocytic cells are the same in every smear and every category, every particular characteristics. Also, this is a Arthur cell now is recommended the definition of oncocytic cells. And this is the difference between suspicious for malignancy we have seen before and papillary carcinoma, the presence of orphan NSI. The presence of this clear-cut orphan NNI in nuclear pseudo-inclusion probably is may prevent a diagnosis of NIFT, non-invasive follicular tumor with papillary-like nucleus structure, because so interesting, significant pseudo-inclusion are not present usually in the NIFT. And this is the diagnosis for a diagnosis of medullary thyroid carcinoma is a mimicker. This is a monophasic with the plasmacytoid cells, and sometimes plasma myeloma, multiple myeloma may be localized in the thyroid. Is very uncommon, but also medullary thyroid is uncommon. So probably we may need something more to make a correct and important diagnosis of medullary thyroid carcinoma, and we'll see further in the presentation. And this is anaplastic thyroid carcinoma, but big killer, the tumor with the large anaplastic cells, but in the center we see a fragment of necrotic tissue. We published, Dr. Bibb of the Thomas Jefferson University in Philadelphia in 2011 asked me and my colleague, Professor Rossi, to present our experience of liquid-based cytology in 2011. But as you can see, this paper by some Indian authors deal again with the analysis of liquid-based cytology, conventionally fine needle aspiration of thyroid lesion. There is the interval is 12 years. But as I told you at the beginning, there was the possibility to apply additional techniques to the material stored in the preserved site solution, stored and not used to have for the diagnosis. But which kind of examination? Immunocytochemistry. Immunocytochemistry is very controversial. Some people don't want to apply immunocytochemistry because of the poor results. But this is a paper published by Professor Crescenzi of Rome and Professor Baloch of UPenn, which in 2023 present the immunostaining profile, and I can tell you that is immunohistochemistry can be applied to the cells stored in the preserved seed solution, so directly on the cells processed by liquid-based cytology. They present many possibilities, and one possibility they present is the diagnosis of medullary thyroid carcinoma. This is suspicious for medullary thyroid carcinoma, but applying immunocytochemical stains for calcitonin on the neoplastic cell, we can make a correct and definitive and significant delicate diagnosis of medullary thyroid carcinoma. But they did not discuss in the paper the so-called markers of malignancy. So the antibodies which are expressed in neoplastic cell, in malignant cells, and they are not usually expressed in the cells which belong to a benign lesion. The most important in our experience are galectin-3 and HbA1, but also cytokeratin 19, thyroperoxidase can be used. But our experience has been started in 2005, but we published our paper in 2011, when demonstrated that the concordant panel made up of HbA1 and galectin-3, when was positive, predicted the malignity on indeterminate, the diagnosis of the third category, the malignancy in 77%, so very high. But the most important is the negative concordant panel predicted a benign lesion in the majority, 97% of cases. So what is the interpretation when the positive immunopanel was present in an indeterminate diagnosis? The lesion, the patient was considered a candidate for surgical removal of the lesion. Whereas when the two the immunopanel concordant was negative, the patient was put in a follow-up program. But also there are also other important and recent description of the antibodies which are recognized, identifies the mutations which are important driver mutation in for the thyroid carcinoma. The most important is the BRAF V600E mutation, and there is an antibody, the VE1, which is useful for identify, this paper published in 2019, to identify the aggressive variant. This is in particular, this is tall cell variant of papillary carcinoma. Or in 2020, our group at the Catholic University demonstrated the importance, the prognostic importance of the PD-L1. PD-L1 is a marker of the so-called immunity checkpoint, which is also important for the prediction of the response to the nivolumab, or so-called inhibitors of the immunity checkpoints. So thyroid is not really very important, but there is an increase of cases which are refractory to the most important treatment, which is the radioiodine treatment ablation. And so can be useful also for maybe anaplastic thyroid carcinoma or squamous cell carcinoma, and for those cases which are refractory to radioiodine. Of course, we are now shifting to the use of the material for molecular biology. We published in 2003 we evaluated the mutation on microcarcinomas, papillary carcinoma, when demonstrated that the analysis, the BRAF mutation analysis, was important in predicting the possibility of metastasis in these cases. BRAF positive had the likelihood of having the positivity of lymph nodes, the cervical lymph nodes. In 2018, our group demonstrated that TeamPrep ensures adequate and valid material for molecular analysis. The mutation is also important of liquid-based pathology, is also important for the next generation sequencing, which is really used now in this for the evaluation of the prognostic and the treatment of these lesions. And in 2020, we devised a gene expression classifier. With the University of Rome, La Sapienza, we put together with the next generation sequencing the gene mutation, gene fusion, gene control, and also the evaluation of the microRNA with the digital PCR. And the paper was published, and we can see that the negative predictive value of 100% was important because this gene expression classifier can be defined a so-called rule-out test. Rule-out test, a test which identifies the benign lesions. If you want to know more regarding the gene expression classifier, the most popular gene expression classifiers, which are very adopted in the United States, and not really in Europe because of the costs. They are not really cost effective, but we see Firma, Thyroseq, Tygen Next, Thyromir. And probably the thin layer cytology can be useful for the coolest subject in this period, that is application of algorithm of artificial intelligence to the cell detection and classification of the thyroid, but not only thyroid, but other fields. Now we will discuss the pulmonary lesion. In pulmonary lesions, there are two most important issues. One is the diagnosis, sometimes based the diagnosis relies on the expression of immuno which identify adenocarcinoma and from squamous cell carcinoma, and this immunocytochemistry can be applied on liquid-based cytology, or also some cell block. Cell block can be taken or can be prepared from the cells which have been after the spinning of the cells, can be collected and to organize a cell block. And also the prediction of the therapeutical response can be done on liquid-based cytology on cell block material. Well, there are some controversy regarding the possibility application, but not really from the technical viewpoint, but also from the conceptual viewpoint, because the problem is the limited number of cells, but this is we can handle this problem, but also probably regarding the possibility of application of techniques from technical problem in evaluating this prediction gene alterations. However, the diagnosis can be done on liquid-based cytology and on cell block, and the prediction of the therapeutic response can be done on liquid-based cytology and on cell block. And this is our experience at the Catholic University, more than 1,000 fine needle aspiration, about 1,000 EBUS endobronchial ultrasonography for thoracic node biopsies, and about 2,000 pleural effusions, so are important. And you can see that the diagnosis is not difficult. This is, of course, a small cell lung carcinoma, but is sometimes to make a diagnosis, we need also immunocytochemistry. But this is a squamous cell carcinoma. This is another carcinoma. But, and we can see that the liquid-based cytology can be useful for the diagnosis on exfoliative cytology, sputum, but also washings of the bronchial tree and the brushing of the mucosa. But it's important also to make a correct, accurate diagnosis for the histological types of lung cancer. This is a group, the Japanese group, and the paper is the paper has been published last year. And we can see that with the salient, there are also other the system, but we used the salient for taking the cells from the liquid for this preserved seat and to prepare the cell block. We can see that an application of TTF1 on a small cell lung carcinoma and CD56, which is very important for making a diagnosis of a small cell lung carcinoma. And I'm presenting some papers regarding the possibility of application of all molecular techniques to liquid-based cytology processed specimen in lung carcinoma for the diagnosis and the prediction of therapeutic response of some lung lesions. Regarding salivary gland lesions, has been published in last year, the second edition of the Milan system. So we have, I was in one a group of chapter of these suspicious lesions, but we have a good experience with salivary gland neoplasm. This is a pleomorphic adenoma with a very nice group of fibromyxoid tissue and a pleomorphic adenoma, but we can make a diagnosis of oncocytic cell and lymphocytic cell for a Warthin's tumor, and this is an adenocarcinoma on liquid-based cytology with a cytokeratin positivity in the cytoplasm. And this is a paper by our group in the Catholic University on lesions of the head and neck. Hepatic and pancreatic lesion and breast lesions. There are many colleagues which are not really very fond in diagnosing and using liquid-based cytology and cytology for diagnosis this lesion. But we can see that these very recent papers are highlight the importance of cytology for pancreatic neoplasm, and in 2019, 2 papers of Journal of Cytology, which highlights the importance of diagnosis of on breast masses and breast lesions. And I will conclude my presentation with the urinary system, the so-called PERIS system for reporting urinary cytology. The second edition was published in 2022. We participated at Catholic University. We, as you can see, many samples, and with many cases, several cases of high-grade urothelial carcinoma, suspicious for high-grade. And you can see that high-grade urothelial carcinoma on liquid-based cytology suspicious are very nice and easy to diagnose and to evaluate. And these are 2 papers by the group of Catholic University regarding the application of the PERIS system on the material processed by liquid-based cytology. So, take-home messages. Liquid-based can be applied to all fields of non-gynecological cytology. The morphological differences between liquid-based and conventional are limited and require a short learning period. Our period of 2 years was because we didn't have any example, any paradigm to follow. The availability of the material left in the vial for the application of molecular techniques may enable the progressive diffusion of the liquid-based technique. So now is probably is why we are here to discuss the possibility, the developments of liquid-based cytology. And the acknowledgement for Professor Rossi and Professor Pierconti of the Catholic University, of Professor Martini and Dr. Fiorentino of the University of Messina. And I warmly invite you in Florence next year in May, very terrific month in Florence, for the International Congress of Cytology organized by the Italian Society and the International Academy of Cytology. And thank you for your attention.
Thank you very much, Dr. Fedda. I love the last picture. Thank you for this fruitful...
I found by chance.
Oh, really? It's really lovely. Thank you for the talk. It was really amazing to see the expert people using the ThinaPrep in different cytology specimen. As I told you before the lecture, myself, I am one of the people that found it really hard to look at the ThinaPrep using the, for the thyroid reporting. Yeah. But we do receive as a referral cases, and hopefully we'll get used to it. Replacing 20 slides by 1 slide, looking at the morphology, more clean background is really something I look forward to it, but it will need some time to adapt it and to be more comfortable in using it. Let me see if we have questions. I don't see questions, but I see a really good number of attendees that did not decline, which is really great. Thank you very much, Dr. Fedda. We really look forward for the Florence meeting. I hope I can attend. Thank you.
Do you have I see some.
You see questions?
Yeah, yes, I've seen. Oh no, there are 3. I can read them.
Okay.
This is there any situation where you recommend both methods? Probably probably when in lung cytology you need to use the rapid on-site evaluation. At least in my experience, in we used for pancreatic cytology and lung cytology, because you can do the rapid on-site evaluation with the conventional smear. Then the majority of the material, when you have evaluated, assessed the amount of material, you can put the remnant of material in the liquid for processing in liquid-based cytology. Can you ask about reactive urine versus high-grade urine anomaly? Well, is not related to really the use of liquid-based cytology. Of course, reactive and high-grade urine are abnormality. Well, sometimes it's very difficult, and the perisystem, you know that the perisystem avoid purposely the differentiation or the diagnosis of the cells of the lesions, the papillary lesion low grade. So is the purpose of the perisystem is to identify the high grade urine urothelial cells. So reactive, but that's why, because papillary low-grade lesion and reactive lesion may be really, really similar. How to differentiate between goiter and follicular lesion in thin prep? Well, the most important thing is to identify the colloid. So when you identify the large amount of colloid, you are absolutely confident that is not an indeterminate lesion. So it's not a follicular lesion. You have to make a choice. If the cells are follicular cells which resemble a carcinoma or suspicious for carcinoma, this is a carcinoma. But if the cells are benign, that do not show atypia, benign, not indeterminate. For learning period of 2 years, do we have to run both conventional LBC? Well, that has been our experience, and the experience was, I would say, not negative, but not positive. So I think that the period should last no more than 6 months. When you decide to shift from conventional to thin prep, in 6 months, you have to organize your system, your lab, your procedure, and 2 years can be really a problem.
And as you said, Dr. Fedda, in your experience, we can go together doing the thin prep and the conventional at the start, and then look how it goes, look how confident the cytoscreener and yourself, and validating your approach, validating your operator, the one who is
agree. And if I can suggest one small trick, please look at the beginning, the thin prep, the liquid-based cytology slide. Then you will have the possibility to make a diagnosis, to achieve a diagnosis. Then probably after a few months, you will completely discontinue the conventional smear. If you are a good cytologist, you have a skilled cytopathology, probably you won't find any particular difference in making a diagnosis with the liquid-based cytology. For learning period of 2 years, do we have to run both? No, I have already. Can we get your professional contact, please? Yes. This is my email guido.fawda at unime.it. This my name, surname, and my university, Messina. Can we differentiate between NIFT and papillary carcinoma? I think that is really, really, really difficult. Do you want to and we are certain cases where it is preferred to avoid the liquid-based cytology method. I don't think there is at the beginning we do use liquid-based cytology for all non-gynecological, and we have also experienced that we can use liquid-based cytology also for cervical cytology. So your laboratory can do everything in liquid-based cytology. I don't have any other questions so far.
Excellent. Thank you very much. It was weird. I don't see the questions, but I'm glad that you were able to see them and answer them. Dr. Feda, it's really a pleasure for us to have you. I enjoyed it personally. We do have a really good feedback. Thank you very much.
Thank you. It's been a nice experience for me. I hope to see you, to meet you, maybe in Florence next year.
Yes, in Florence in 2025. And for those who missed part of the presentation, I would like to see it more. It's already recorded and will be uploaded in SSMC Abu Dhabi Surgical Pathology Journal Club website. Thank you very much, Dr. Feda, and have a great rest day. Thank you.
Thank you. Thank you. You're welcome. Thank you.